Welcome to ABG Extra Edge. This was a basic ABG course that we have completed recently. I have discussed the fundamental definitions, approach through an algorithm, metabolic acidosis, high anion gap, normal anion gap, metabolic alkalosis, respiratory acidosis, respiratory alkalosis, mixed acid base disorders, delta concept. In the Extra Edge course, this is specially designed so that it can give you extra information and better understanding of cellular mechanisms also. We will discuss buffering mechanisms, assessment of oxygenation, what is the standard bicarbonate, actual bicarbonate, base excess, mechanisms of renal diseases, validity of ABG and ABG sampling. These are the things that we are going to discuss here. Now let us start our discussion. We are going to start with the basic buffering mechanisms. For that, how is the pH in your blood regulated? We have chemical buffers. Three types of buffers are seen: chemical buffers, respiratory system buffers, renal system buffers. Chemical buffers, the action is immediate. These are something acting immediately and it will bind to acid or base. The role of any buffer is to limit the pH change. It makes sure there is no excess change in the pH. Then respiratory system acts within minutes. And how does it maintain acid-base balance? By controlling the carbon dioxide. This chemical buffer, it is going to bind with acid or base and it is going to control the change in pH. Whereas respiratory system, it is going to control CO2. Either it eliminates CO2 or it retains CO2 to maintain the acid-base balance. Whereas kidney, it takes about hours to days for its function to happen, and it is most important. It is even ultimately handling acids and bicarbonate. Out of these three, most important will be renal system, and it is also the strongest, and weakest is generally chemical buffers. Let us start with what exactly is meant by a chemical buffer. As I told you, buffer is a substance which limits the change in pH. It is going to make sure the pH is not changing excessively. Let us see with an example. I say buffer is similar to a sponge. I say buffer is similar to a sponge. Now if you notice here, whenever there is excess H plus coming as a stream of water. Now so many H plus have entered into the body. Now what will this sponge do? It will make sure it is binding with all those H plus and it will limit the change in pH. Now whenever your body is not having proper H plus, now this sponge is going to release H plus. Here it is binding with H plus. It is binding with H plus when there are excess H plus. When there are less H plus, this buffer can release H plus. All this is done so as to maintain pH within the near normal limits. When there is excess H plus in your body, this can bind with the extra H plus to maintain the pH. Very simple. When the H plus is low in your body, the sponge can be squeezed out. It squeezes out to release ions. This is not as simple as this when you see in your body, but for your understanding, you can consider a buffer equivalent to sponge. It can reabsorb H plus when it is excess in your body. It can release H plus when your body is in need of H plus. These chemical buffers can be again divided into those important in the extracellular fluid, important in the intracellular fluid. Extracellular fluid buffers intracellular fluid buffers. Extracellular fluid, we have most important is bicarbonate. In the extracellular fluid, if they ask you what is the most important buffer, you should be knowing it is bicarbonate within the extracellular fluid. Whereas intracellular fluid, we have proteins, phosphates, and these proteins are the most abundant buffers. Within the extracellular fluid, most important is bicarbonate. Within the intracellular fluid, important and abundant are usually proteins. We also have a phosphate buffer. Let us see how these buffers are acting on your body. Now this bicarb buffer works on this equation. The principle is this equation: bicarbonate buffer, CO2 plus water, CO2 plus water with the help of carbonic anhydrase. It is going to give rise to carbonic acid that will give rise to bicarbonate plus H plus. Point to be noted, this reaction can happen in both ways. Depending upon the concentration of reactants versus products, it can happen in any ways according to the need of the bodies. Very important. This equation can happen in any of the direction according to the need of the body. Let us see the need of the body. This equation follows law of mass action. This is the law of mass action. Simple school level chemistry. It mentions that rate of chemical reaction is proportional to concentration of reacting substances. Now suppose the concentration of CO2 has increased in your body. This equation will predominantly move in this direction. Rate of chemical reaction proportional to concentration of reacting substances. Now if at all H plus has increased in your body, now the reaction will move. Typically in this direction. Reaction will move typically in this direction. This is the law of mass equation, which mass action, which tells you that the rate of chemical reaction is proportional to concentration of reacting substances. Let us see for an example. In your body, a strong acid is added. Let us say HCl. Now what will any acid ultimately give rise to? It gives rise to excess H plus. Whenever there are excess H plus, how is this bicarbonate buffer going to maintain the pH? Very simple concept, students. What you need to know is, this is the basic equation. Now to this body, H plus has been added. Now because H plus has increased significantly. Now the equation will travel in this manner. All this excess H plus will be bound by your bicarbonate. It will be converted ultimately to carbon dioxide, which can be expelled out, by your lungs. All the excess H plus is ultimately made into carbon dioxide, which can be expelled out. Because this is converted into carbon dioxide and it is expelled out, pH change can be prevented. This is how bicarbonate buffer acts when a strong acid such as HCl is added. Whenever acid is added, that acid gives rise to so many H plus. These H plus, they now make the reaction to go in this direction, ultimately forming CO2, which will be expelled out. Because of this, the pH change will be prevented. Now let us see what happens when a strong base like NaOH is added. This is more simple. NaOH directly reacts with H2CO3. resulting in NaHCO3 plus H2O. Now where is this H2CO3 formed? H2CO3 is formed because of combination of CO2 and H2O. Now because excess H2CO3 is getting consumed by NaOH, because it is getting consumed by NaOH, Your body should make sure CO2 is staying in the body. The consumed H2CO3 is replaced by CO2 combining with H2O. Whatever bicarbonate is getting consumed. Now your body, what it does, it will make CO2 to react with H2O. Now CO2 has to stay in the body in adequate quantities. Because of that, what your body is going to do, it is going to slow down the rate of CO2 expiration. To maintain CO2 levels in the body, to maintain CO2 levels so that it can bind with H2O and form H2CO3, there can be slowing down of respiration. There can be slowing down for respiration. Now in this equation, ultimately whatever bicarbonate is formed, here also you will be having bicarbonate, sodium bicarbonate. It is compensated by increased renal excretion of bicarbonate. All this bicarbonate which has been formed can be excreted out by your kidney. In simple words, whenever acid is added, whenever there is acid, increased H plus in your body, this will be expelled as CO2. Here there will be increased respiratory rate. Whenever a base is added, what ultimately happens, there will be reaction between the base resulting in base and carbonic acid resulting in bicarbonate. And whenever base is added, what is going to happen? CO2 retention can happen, resulting in decreased respiratory rate. Why CO2 retention should happen? Because the base is ultimately going to react with this carbonic acid. There will be movement of this equation in this direction, because CO2 is more required to replace the consumed H2CO3. What happens is CO2 will be retained in the body, so the respiratory rate transiently can decrease. Whenever acid is added, the respiratory rate increases and acid expelled out as CO2. Whenever base is added, to react with that base you need an acid. What is the acid? It is carbonic acid. Where is carbonic acid formed? From CO2. In simple words, when acid is added, it is expelled out as CO2. When base is added, it reacts with carbonic acid. To keep carbonic acid in your body, CO2 should retain. When base is added, there can be decrease in respiratory rate or slight depression of the respiration. This is how bicarbonate acts to minimize the change in pH whenever strong acid or base is added to your body. Coming to phosphate buffer. Phosphate buffer works on this principle. Dihydrogen phosphate, this is two hydrogens. Dihydrogen phosphate gives rise to monohydrogen phosphate plus H plus. This is how phosphate buffer is going to act. Let us see few scenarios. Whenever strong acid such as HCl is added, so whenever strong acid is added, lot of H plus are getting accumulated into the body. Now because H plus has increased, this side the substances have increased, so the reaction will predominantly move in this direction. All the excess H plus found in your body now binds with this monohydrogen phosphate, giving rise to dihydrogen phosphate. Because H plus are getting consumed by the phosphate buffer, the change in pH is minimized. pH can be maintained. Now second scenario, let a base be such as NaOH be added. This NaOH directly reacts with H2PO4. This NaOH directly reacts with H2PO4, resulting in HPO4 2-. You can see here there is reaction between H2PO4 and OH-. From the OH-, this is the important part of the base. It can react with H2PO4 resulting in HPO4 2 minus and H2O, because OH minus ions are removed. If OH minus ions are excess in the body, it will go and bind with H plus. It will reduce the H plus in the body and it can result in alkalosis. Now this OH minus should be removed so as to pH should not change in the body. This H2PO4 reacts with OH minus, forming HPO4 2 minus and H2O. Because OH ions are removed, pH is maintained. In simple words, when an acid is added, it is consuming H plus so that pH will not change. When a base is added also, this will consume OH minus so that pH is maintained. In the same way, in the red blood cell, hemoglobin is an important buffer. Hemoglobin is an important buffer. It works on this principle. H plus hemoglobin gives rise to H hemoglobin. In the same way, whenever there are excess H plus in your body, this equation can travel in this direction. What happens is, hemoglobin binds with H plus, resulting in consumption of H plus. Whenever in your body H plus reduces, now what happens? Now let us say this is the first scenario when there is excess H plus in your body. Now hemoglobin binds with H plus and the reaction will travel in this direction. Because hemoglobin is binding with H plus, the change in pH can be prevented. Now suppose because of some disease there is significantly low H plus. Now what happens is, this equation will travel in this direction. Whenever equation travels in this direction, what is happening? H plus will be released in your body. Whenever there is excess H plus, hemoglobin consumes that H plus and minimizes the change in pH. Whenever there are less H plus in your body, this HHB releases H plus and it will try to maintain the pH. In red blood cell, hemoglobin is also important buffer. This is how it acts. It either accepts H plus, minimizes the change in pH, releases H plus, minimizes the change in pH. It is all according to the clinical scenario of the patient. If some acid is added, H plus increases in the body, hemoglobin binds with it. Whenever a base is added, H plus decreases in the body, H plus is released into circulation from the hemoglobin and HHB complex. This is important. Coming to respiratory regulation, very simple. Respiratory regulation can deal by either CO2 washout or CO2 retention. This is the relation. Whenever in your body H plus increases, whenever there is an clinically important acidosis, this H plus can directly stimulate the ventilation. Whenever the ventilation is stimulated, there will be CO2 washout. So when there is an acidosis, ventilation will be stimulated. CO2 is an acid-like substance. Because CO2 is washed out, H plus in your body will come back to near normal. Whenever there is an alkalosis, whenever H plus reduces in your body, that is called as alkalosis. During alkalosis, what will happen during alkalosis? So let us say this is alkalosis. H plus in your body reduces. So what your respiratory system does, it decreases the ventilation. Because of that, CO2 increases in your body. Whenever H plus decreases, your body tries to increase CO2 in your body. Whenever CO2 increases, the H plus will increase so that the H plus will be maintained to near normal. This is what is happening. In scenario 1, this is scenario 1 students, where there is acidosis. This is scenario 2, where there is alkalosis. When there is acidosis, already in your body there will be increased H plus. How will your body fight? By sending acid called as CO2 out, alkalosis. Now there is less H plus. Now how will your body fight? If there is alkalosis, your body will fight by retaining acid. If there is acidosis, your body will fight by sending out acid. This is a simple defense mechanism. By that, your pH will be maintained to near normal. This is respiratory regulation. Either by CO2 washout or CO2 retention, it is going to maintain the pH. Then coming to most important, that is renal regulation. Renal regulation has multiple roles. It is not just like a single gas like CO2 when compared to respiratory regulation. It has so many roles. First important is it can excrete acids. It is going to excrete acids. In your body, so many acids are formed. All these acids ultimately, predominantly will be excreted. The other acids which cannot be converted into CO2, the other acids such as your lactates, all these acids ultimately will, keto acids ultimately will be excreted by the kidneys. Reabsorption of filtered bicarbonate. In the urine, there will be lot of bicarbonate getting filtered at the glomerulus. All this bicarbonate is required for your body's function. It will be reabsorbed by the kidney, and also there is a need for production of new bicarbonate. Your kidney also ensures new bicarbonate is produced. Daily about 70 to 80 milli equivalents of fixed acid is excreted by the kidney. Just know what is this sentence. I will explain everything in detail. About 70 to this number, 70 to 80 milli equivalents of fixed acid will be excreted by the kidney. Now for this excretion, let us say 80 milli equivalents. What is this fixed acid? I'll just let you know in a short while. Let us say about 80 milli equivalents of bicarbonate is used up for this fixed acid. Now because 80 milli equivalents is used for this fixed acid, your kidneys will also generate 80 milli equivalents of bicarbonate per day by secretion of H+. Your kidney is a wonderful organ. It makes sure no bicarbonate is getting wasted in your body. To excrete fixed acids, your kidney is getting 80 milli equivalents of bicarbonate used up. And your kidney, again, whatever bicarbonate is used up, it is going to regenerate that 80 milli equivalents. This is the importance of this phrase, production of new bicarbonate. This production of new bicarbonate is necessary because kidney is going to excrete some fixed acids. All these fixed acids will consume bicarbonate, and these consumed bicarbonate will be produced again, will be regenerated by your kidney. Let us see the concept behind this. Acid excretion can be divided into two types: volatile acids and non-volatile or fixed. Volatile means which can be excreted through gaseous form. You must be knowing, as a part of metabolism, it can be converted into CO2, such as carbohydrates and fats. Carbohydrates and fats, the ultimate result will be carbon dioxide. This carbon dioxide can be converted to gas. This is a gas form. It can be expelled. Whenever there is metabolism of carbohydrates and fats, there will also be production of acids. But very important feature of these acids are, this can be converted ultimately to CO2. Let it be metabolism of carbohydrates and fats. In between there will be acid. And the end result of all these steps, pyruvic acid, all these steps will generally be formation of carbon dioxide and water. This carbon dioxide can be easily removed by your lungs. Whereas there are other acids such as fixed acids. Where are they formed from? These cannot be excreted by the lung because they are not going to give CO2 ultimately. They are not going to give CO2. They cannot be excreted by lung. Metabolism of few proteins. Metabolism of few proteins. Example, metabolism of few proteins. Example, cysteine methionine. Cysteine methionine. So this cysteine and methionine, it gives rise to H2SO4. It gives rise to a fixed acid. Now this H2SO4 cannot be excreted directly by your lung, because if you see carbohydrates and fats, they give rise to CO2 and H2 ultimately. But here these are not giving rise to CO2. They are giving rise to acids such as H2SO4. This is a fixed acid. This H2SO4 is a fixed acid. Now to excrete this, what your kidney does is it utilizes bicarbonate. With the help of bicarbonate, this fixed acid is converted into CO2, H2O, Na2SO4. All this can be excreted ultimately by your body easily. In simple words, fixed acids are those which cannot form CO2 directly. For that, you are using your kidney's bicarbonate. Now suppose a cysteine or methionine is metabolized, it is forming H2SO4. For this H2SO4 to be excreted, you are using bicarbonate. Like this, about 80 milliequivalents of fixed acid is excreted by kidney, and for this 80 milliequivalents of fixed acid, 80 milliequivalents of bicarbonate per day. Now you can see here there are 2 H plus getting out eventually. For this 2 bicarbonate will be used up by your kidney. All this bicarbonate consumed as a part of excreting this fixed acid will also be produced by your kidney. So the important roles of the kidney: excretion of acids, that is H plus. Excretion of acid in the sense it is going to excrete the H plus of acid, reabsorption of filtered bicarbonate, production of new bicarbonate whenever it is getting utilized during excretion of fixed acid. Now let us see the roles. Again, bicarb balance. The roles are excretion of acids, reabsorption of filtered bicarbonate, production of new bicarbonate. Then coming to the bicarbonate balance. These are the few important numbers that you should know. Daily about 4320 milliequivalents of bicarbonate is filtered into the tubular fluid per day. You know that this is your glomerulus. Into the tubular fluid about 4320 milliequivalents of bicarbonate. Into the tubular fluid about 4320 milliequivalents of bicarbonate is coming, and all this bicarbonate should be later taken into the body. All this bicarbonate from the urine will be taken into the body. Along with this, what your kidney does, it is going to regenerate 80 milliequivalents which have been consumed for fixed acid. So total bicarbonate reclaimed by your kidney ultimately will be 4320. What is this 4320? It is the reabsorbed bicarbonate. It is new regenerated bicarbonate. If they ask you total bicarbonate reclaimed by your kidney per day is 4400 milliequivalents. Out of this, 4320 which generally comes into the urine is reabsorbed. 80 is newly generated. Coming to the systems where your kidney plays a major role, the proximal tubular system. Within the proximal tubular system, there are 2 mechanisms in the kidney roles: reabsorption of bicarbonate. Proximal tubule is responsible for reabsorption of bicarbonate and production of NH4+. Now why this production of NH4+ happens, I will discuss in the next slide. Reabsorption of bicarbonate, very important. 85% of reabsorption happens in the proximal convoluted tubule. That's why PCT is very important part in the kidney. 10% will happen in the thick ascending limb of loop of Henle. So this is in the loop of Henle, 10% reabsorption of bicarbonate, and 5% in the distal tubule collecting duct. 5% in the distal tubule and collecting duct. In all this, let it be PCT, let it be loop of Henle, let it be in distal tubule and collecting duct, the mechanism will be the same. Because majority happens in the PCT, we will discuss it as a proximal tubular mechanism. Let us see how bicarbonate is getting reabsorbed. Let us take, this is the 3-compartment diagram, the renal cell. This is the tubular lumen which contains urine. This is the interstitium which represents the blood concentration. Renal cell, urine, blood. These are the 3 compartments. Already I told you, in your body always bicarbonate is getting filtered into the urine. Bicarbonate has been thrown into the urine. Now my body should make sure this bicarbonate is coming inside. By any manner, by hook or crook, I should make sure this bicarbonate is reaching into my body. For that, what are the steps? First step is, within the renal cell, as a part of metabolism or diffusion from the blood or urine, CO2 accumulates. This CO2, this is the first step. This CO2 combines with water. This CO2 combines with water and it gives the product called as H2CO3. This H2CO3 will dissociate into HCO3 minus and H plus. This H2CO3 is going to dissociate into HCO3 minus and H plus. My kidney always tries to take bicarbonate and throw H plus. So this is its tendency. Anywhere it will try to reabsorb bicarbonate and throw out H plus. Let us see how it is doing further. The next step, the H plus secreted from the cell. The H plus is secreted from the cell into tubular lumen. Now you have a H plus here. This is secreted from the cell, renal cell, into the tubular lumen by sodium H plus counter transport. This H plus, it is going into the tubular lumen. For whatever H plus has gone into the tubular lumen, sodium is coming into the renal cell. Later it will be going into the blood with a Na plus K plus exchange. So ultimately, for whatever H plus is coming into the urine, Na is going into the body or it is going into the renal interstitium. Now the third step. So this is the second step. The H plus is getting excreted, excreted or secreted into the urine. The third step is the bicarbonate that has been generated in the cell. Now you have a bicarbonate here. You have a bicarbonate. This is the third step. So this bicarbonate generated in the cell moves into the renal interstitial fluid. This renal interstitial fluid is nothing but your blood, your body's concentration. Now bicarbonate has come into the blood. Now what happens in the urine? Now you have a bicarbonate and H plus. Both will combine and gives rise to CO2 plus H2O. And these CO2 and H2O, this CO2 can get diffused into the renal cell and this cycle can continue. Now if you notice here, the net result is for whatever, see, observe here students, whatever H plus has been excreted into the urine, what has went into the blood? Bicarbonate. The net result is, for every H plus secreted into the tubular lumen, bicarbonate enters the blood. Very important mechanism. CO2 plus H2O. This was the first step. It was giving rise to H2CO3. This divided into H plus and HCO3 minus. H plus went into the urine because Na plus has been taken in. So Na plus ultimately reaches the blood. But important, let us see how H plus is excreted, how bicarbonate is going into your body. Now the H plus secreted into the tubular lumen, the second step, by sodium hydrogen counter transport. Now whatever bicarbonate has been generated here within the renal cell is going into your blood, and HCO3 in the urine and H plus reacts, forming CO2 and H2O, where this CO2 can diffuse back into the renal cell when required, and this process can continue. The net result is, for every H plus secreted into the tubular lumen and bicarbonate enters the blood. This is the reabsorption of bicarbonate. This happens in proximal convoluted tubule, thick ascending limb, and minority in the distal tubule and collecting duct. Next important mechanism in the proximal tubules is, this was a proximal tubular mechanism that we have discussed, how it is going to reabsorb bicarbonate. Next is the production of NH4 plus. This is what is happening. There is a substance called as glutamine. Most of the postgraduates in your final year exams, in the theory paper, the mechanisms of renal mechanisms of acid-base balance will be an essay question, or they'll ask you what are the defense mechanisms in your body against acid-base disorder. You should be knowing the mechanisms of chemical buffers, respiratory system and renal system. Any one of this can be given as an essay. I have made it easier for you to represent in the exam. I have written in slides and I have highlighted the important points in the boxes, so that it will be easier for you to represent in the exams. In the renal cell, there is a substance called as glutamine. This glutamine will be metabolized into NH4 plus and bicarbonate. The concept here is, for each molecule of glutamine metabolized, 2 NH4 plus are secreted into the urine. 2 NH4 plus are secreted into the urine and 2 bicarbonate are reabsorbed into the blood. Very, very important. If glutamine is getting metabolized in the renal cell, depending upon the body's requirements, it will be metabolized. What is coming into your blood? 2 bicarbonate is coming into your blood. What is going out into the urine? 2 NH4 plus is going out into the urine. 2 NH4 plus is going out into the urine. Final result will be the bicarbonate generated by this process constitutes the new bicarbonate. Previously, there was a bicarbonate in the urine. So this bicarbonate used to combine with H plus, it used to give CO2 plus H2O. This CO2 used to come into the cell, again the process used to continue, and there was bicarbonate going into the blood ultimately. That was what we have discussed previously, reabsorption of bicarbonate in the proximal convoluted tubule. Here nowhere there is already a pre-existing bicarbonate. It is not for the pre-existing bicarbonate in the urine. It is a new bicarbonate. The bicarbonate generated by this process constitutes a new bicarbonate. This again, sodium can be taken in for whatever NH4 has gone out. Sodium can be taken in and sodium and bicarbonate goes into the blood. Ultimate result is, for glutamine, when it is metabolized in the PCT, 2 bicarbonate are coming into the blood and this bicarbonate constitutes new bicarbonate. Coming to distal tubular mechanism, in the distal tubules, especially in the distal tubules, most important will be the collecting duct where acidification of urine happens. Apart from this, what are the other functions? Reabsorption of remaining filtered bicarbonate. We have discussed in the distal tubule about 5% of filtered bicarbonate can be reabsorbed. It is with the same mechanism that we have discussed in proximal convoluted tubule. Then formation of new bicarbonate with phosphate and NH4 buffer. This is very, very important. This is very, very, very important. This is responsible for acidification of urine. This mechanism is responsible for urine getting acidified ultimately. Net excretion of acid occurs primarily in the distal nephron, net excretion of H plus, by active secretory pumps. There are two important secretory pumps. One is H plus K plus ATPase and other is H plus ATPase. Now let us see how new bicarbonate is formed with the phosphate and ammonium buffer. Now suppose there is CO2 plus H2O. The CO2 can either come from the blood or from the urine. It can diffuse into the cell, giving rise to H2CO3, that ultimately gives rise to H plus and HCO3 minus. That ultimately gives rise to H plus and HCO3 minus. Now there will be a H plus K plus ATPase. H plus K plus ATPase pump in the distal nephron. H plus K plus ATPase pump in the distal nephron. This pump is responsible for H plus going into the urine, K plus coming back into the renal cell. So this pump is called as H plus. H plus is going into the urine, whereas K plus can come back into the cell. This is called as H plus K plus ATPase pump. Now the end result is H plus going into the urine. Now within the renal cell there can be NH3. This NH3 goes into the urine, and this NH3 is now going to react with H plus, and that results in formation of NH4 plus. The ultimate result is NH4 plus is formed, and with this NH4 plus there is excretion of H plus. There is H plus getting excreted. For H plus getting excreted, there is H plus getting excreted. And what else has happened? This bicarbonate is a new bicarbonate. It is excreted into the blood. See, by the time urine comes into the distal tubule, majority of bicarbonate will be reabsorbed. So there will be no bicarbonate in the urine. So bicarbonate will be very, very less. Now how to excrete H plus here? CO2 plus H2O gives rise to H2CO3. This is an independent mechanism where there is a H plus ATPase pump. Previously in the proximal tubules, it was having bicarbonate, so H plus was binding with bicarbonate and it was going out in the urine very well. Now here for H plus to go into the urine, we need something to bind it in the urine, that is NH3. See, what is the reason for this NH3, why this NH3 and H plus binding is very important? Because H plus will be bound with NH3 and there will be NH4 formation. Because there is a NH4 formation, there will be always a constant gradient. See, if there was no NH3, so H plus will be in the urine. So because of that, the H plus in the urine increases, and the H plus from the body which has to go out will not have a concentration gradient. It will not have a concentration gradient. In the distal tubule, it is the main center for acidification. If H plus has to go into the urine, there should be a concentration gradient. Now because H plus coming into the urine is bound with NH4 plus and NH4 plus is formed. Because of this, effective free H plus in the urine will decrease. So always there will be concentration gradient for H plus to go into the urine. This facilitates renal acidification. If acidification has to happen in the urine, H plus should be less, so that more H plus from the body can be dragged into the urine. For H plus to be dragged into urine, there should be a concentration gradient. This NH4 plus and phosphate buffer make sure there is no free H plus in the urine. It makes sure a concentration gradient is built up for H plus, so that H plus from the body can easily go into the urine. Now the end result here is, for each NH4 excreted, a new bicarbonate is generated and added to the blood. Very, very important. For each NH4 excreted, a new bicarbonate is generated and added to the blood. Now this is distal tubular mechanism of acidification of urine, maintaining H plus gradient by forming NH4 ammonium. Now let us see how it happens with respect to phosphate buffer. The steps are similar. Except one change. See here. CO2 plus H2O gives rise to H2CO3, that gives rise to H plus and HCO3 minus. Now this H plus, with the help of H plus K plus ATPase, is going into the urine. This was the common thing. This H plus is coming into the urine. Now what happens is, in the urine there is a buffer HPO4 2 minus. So this is monohydrogen phosphate. These two bind together and forms H2PO4. Now the H plus excreted as H2PO4, for all practical purposes, it is also called as titratable acid. When they ask you what is titratable acid, it is the acid or H plus excreted as H2PO4. H plus excreted as H2PO4. Now if you notice here also, for each H2PO4 excreted, now this H2PO4 is excreted. Now what has happened? An HCO3 formed in the renal cell is going into the blood. For whatever H2PO4 has been found, a new bicarbonate is going into the blood. So this is the mechanism of regeneration of bicarbonate. With respect to ammonia buffer that we have seen previously, with respect to phosphate buffer, whatever H plus is excreted with help of phosphate buffer, it is also called as titratable acid. This is also called as titratable acid. These are the important mechanisms. We have discussed chemical buffers. We have discussed the respiratory mechanism. We have discussed the renal mechanism. In the renal mechanism, proximal tubular mechanism, how bicarbonate is reabsorbed. Again, in the proximal tubular mechanism, by the metabolism of glutamine, production of NH4 plus and the new bicarbonate generation. Then in distal tubular mechanism, with the help of phosphate buffer, with the help of an ammonium buffer, we are having new bicarbonate getting regenerated. This is important. Buffering mechanisms can be asked as an essay question for residents. Coming to oxygenation, assessment of oxygenation. You should know what are these terms. What is FiO2, what is SpO2, what is PaO2. I will make it in a simple manner. Now if you take room air, majority is made up of nitrogen. Majority, about 78% is nitrogen. And oxygen is about 20.95, 21%. We take it as 21%. This is called as FiO2. The amount of oxygen available in the atmosphere, fractional concentration of oxygen in inspired air. This is FiO2. Now what is SpO2, PaO2? Oxygen transport in your body happens either bound to hemoglobin or dissolved in the plasma, either dissolved form or bound form. Whatever is bound to hemoglobin, it accounts for saturation. Whatever is dissolved, it accounts for partial pressure. There is a law of gas that says that for a gas to exert partial pressure, it should be dissolved in the solution. For PaO2 to happen, the prerequisite is it has to be dissolved. PaO2 is the dissolved form of oxygen in the blood. SpO2 is the amount bind to the hemoglobin. How is SpO2 known? With help of a pulse oximeter. How is PaO2 accurately known? With the help of an arterial blood gas. Then coming to alveolar gas equation. How to measure alveolar gas, alveolar oxygen? You must be knowing this is your alveolus. Whatever oxygen is present in the alveolus, it is PAO2. Whatever ultimately reaches the circulation and you measure with help of an ABG, it is PaCO2. So this is PaO2, sorry, this is PaO2, arterial oxygen, PaO2. This is measured with help of an ABG. But alveolar oxygen within the alveoli, it has to be measured with alveolar gas equation. The formula PAO2 is equal to P atmospheric. Generally it will be 760 minus water vapor pressure. It will be 47 into FiO2 minus PaCO2 by R. R is nothing but the respiratory exchange ratio. Generally it will be about 0.8. So the R is the respiratory exchange ratio. Generally it will be 0.8. So that is a constant value. Now how to calculate alveolar oxygen? And always between alveolar oxygen and arterial oxygen there is a difference. So this difference is called as alveolar arterial gradient. This difference between alveolar oxygen and arterial oxygen is called as alveolar arterial gradient. Very simple. A question: a 24-year-old woman was brought to the emergency room for after attempting suicide with an overdose of heroin. She is obtunded and has a respiratory rate 6 breaths per minute. She is hypotensive. Her ABG is given. What is the AA gradient? If you want to know the AA gradient, we need two values. One is PaO2. This is 42 mmHg. And for knowing AA gradient, you should also know PAO2. How is PAO2 calculated? With this formula. We know that normal atmospheric pressure is 760. Normal water vapor pressure is 47. FiO2 will be 0.21 minus PaCO2 is 80, R value is 0.8. So if you calculate this 760 minus 47 into, so this value will be about 150. 760 minus 47 into 0.21, it will be about 150, whereas this value 80 by 0.8 will be about 100, so 150 minus 100, it is 50. So we got alveolar oxygen 50. Arterial oxygen 42. 50 minus 42, it is 8 mmHg. The alveolar arterial gradient is 8 mmHg. Normal value is, it can be 5 to 15 mmHg. The alveolar arterial gradient is 8 mmHg and normal value is generally less than 15 mmHg. So students, for assessment of oxygenation, not only PaO2 is important, you should also know how to calculate alveolar oxygen. This is the formula. And you should also keep a note on alveolar arterial gradient. In this slide, we have understood the importance of PaO2. PaO2 is for assessment of oxygenation. So this PaO2 is for assessment of oxygenation. For knowing oxygenation, first important parameter is PaO2. Second important parameter is alveolar oxygen. You should also keep an eye on the alveolar oxygen. You should know what is the alveolar oxygen in this patient. And third important thing is you should calculate the gradient. This is what I say to all my residents. So in an ABG, just don't see the oxygen. Always calculate alveolar oxygen. Don't just see the arterial oxygen. Calculate the alveolar oxygen and also calculate the gradient. It will give you so much of information. Now, why this AA gradient is very important, I will let you know in the next slide. The hypoxemia. Whenever a patient reaches to you with hypoxemia, so there is a low PaO2. Now there is low PaO2. There is a patient with hypoxemia. Now you should see the AA gradient and based on AA gradient, you should divide the patient into two. Is it normal AA gradient or is it elevated? Normal means it will be 5 to 15 mm Hg. Generally more than 15, usually taken 20 mm Hg. If it is high, it is elevated AA gradient. Elevated AA gradient, the reasons can be ventilation perfusion mismatch, a diffusion defect. Ventilation perfusion mismatch can happen in pulmonary embolism, can happen in COPD emphysema. Diffusion defect can happen in interstitial lung diseases. Shunt can happen in severe pneumonia, ARDS. Then normal value, if it is normal, it can be either patient who has been in high altitude sickness, or hypoventilation. Hypoventilation, whenever there is reduced respiratory effort, either due to narcotic use, brainstem injury, some neuromuscular disorders, all this come under hypoventilation. Now this hypoventilation and high altitude with a normal gradient, how it has to be differentiated? Hypoventilation itself means decreased respiratory effort. Whenever respiratory effort decreases, what will automatically increase? PaCO2 increase. Based on PaCO2, if it is elevated, hypoventilation. If it is a normal, high altitude. So this is the importance of AA gradient. Whenever there is a patient with hypoxemia, see the AA gradient. If the AA gradient is normal, you think of hypoventilation, high altitude. If the AA gradient is elevated, think about ventilation mismatch, ventilation perfusion mismatch, diffusion defect, shunt. And if the gradient is normal, now see the CO2. If CO2 is elevated, it should be a pure hypoventilation. There can be mixed cases where AA gradient can be elevated and also CO2 can be elevated. For example, in severe COPD. In severe COPD, there can be elevated AA gradient due to involvement of alveolar capillary valves. Because the alveolar capillary valves are involved, the diffusion and ventilation perfusion mismatch, diffusion defect and ventilation perfusion mismatch can exist. Along with that, because of severe airway narrowing and some diaphragmatic dysfunction, CO2 will also be not expelled out properly. So all this will help you to know what can be the possible disease. Point to remember, in assessment of oxygen, don't just see PaO2. Calculate alveolar oxygen. Look at the AA gradient and think about these differentials. Then coming to validity of ABG report. Nowadays we are using standardized missions. Generally the lab errors of ABG because of the mission calibration dysfunction is not happening. But you should know how to assess whether the ABG report is right or wrong. For this there is a formula. H is equal to 24 into PCO2 by bicarbonate. We know that H plus concentration is proportional to PaCO2, because if PaCO2 increases, H plus increases by bicarbonate. The same thing we are modifying it into a standard formula. H plus is equal to 24 into PCO2 by bicarbonate. We know that the ABG mission directly calculates the pH. It calculates the pH. But I want to know the H plus concentration. To know the H plus concentration, this is the formula. And you should know the standard values. For what H plus, what will be the pH. This is the table. Now suppose H plus concentration is about 40 millimoles per liter. If it is about 40 millimoles per liter, the pH should be about 7.40. Now if at all H plus concentration is about 60, the pH should be about 7.20. If it is 50, pH should be about 7.30. Both should correlate. If H plus concentration, after calculating with this formula, if it is 32, the pH value should be 7.50. If both are correlating, it means it is a correct ABG. There is no error. If these both are not correlating, you got H plus value as something, but pH is 7.50, it means it can be lab error if both are not correlating. The H plus value that you have calculated using this formula, the H plus value that you have calculated using this formula, and pH given by the emission, if both are not correlating, it can be a lab error. It can be a lab error. Now let us see with an example. pH 7.30, PCO2 38, PCO2 38, and we have bicarbonate 30. Now let us see whether this is correlating or not. If you see the parameters itself, pH is reduced, CO2 is reduced, bicarbonate is increased. So something is not proper here. Generally, if it is a simple acid base disorder, primary change and compensation should be moving together. CO2 and bicarbonate should be moving together. Here only we can say that there is some problem with the ABG, but let us confirm. So I am going to calculate what will be the H plus of this patient to this CO2 and bicarbonate. I am substituting 38 by 30, 38 by 30. Now this will be roughly about 1.25, 30 by 38 by 30. And if you see here, the H plus concentration will be 30. The H plus concentration will be 30. Now if you notice, if H plus concentration is somewhere 30, what should be H plus concentration is somewhere 30. What should be the pH? 7.50. Now if you see here, in this question, the pH is 7.30. At 7.30, the H plus concentration should be 50. So it is not correlating. H plus concentration should be 50. But when I have calculated, it is only 30. It is only 30. So this is a lab error. This ABG is invalid. To say whether the ABG is valid or invalid, we use this validity of ABG formula. This is a lab error. The H plus that I got with this parameters is 30, but at pH of 7.30, this has to be 50. H plus has to be 50. I got it 30. There is some lab error. In your exam or in your day-to-day practice, what happens is you will not be given this table. You may not be having this table with you, or it might be difficult to memorize this pH and H plus values. For that I have made a simple mnemonic. For that I have made a simple mnemonic. See, consider for pH of 40, for pH of 7.40, let us take H plus concentration as 40. H plus concentration as 40. Now let me decrease the pH. Let this be 7.20. On this side 7.50, 7.60. In majority of clinical scenarios, we will be seeing pH ranging from 7.20 to 7.60. Now what will be the probable H plus values? So for this it is 40. For this it is 40. As pH decreases, H plus generally increases as pH decreases. As pH increases, H plus decreases. Now keeping that in mind, from 40, this will become 50 here. Here it is 60. Now if you see in the original table also, at 7.30, it is 50. Okay, correlating. At 7.20, it is 63. 60 is okay, no problem. So very easy to remember. 7.40 pH, H plus will be 40. 7.30 H plus, I have increased it by 10, 50. H plus at 7.20 will be 60. In the same way, 7.50, so this is 40. Now H plus should decrease. It will decrease by 10, 30. Now if you see in the original table also, it is 32, no issue. And here it will decrease to 25. This is an easy way. Make sure that you know at 7.40 pH, H plus will be 40. Now 7.40 pH, H plus is 40. Now if pH is decreasing, at 7.30, H plus will be 50. At 7.20, H plus will be 60. So 40, 50, 60 on this side. So let the pH increase. At 7.40, pH was 40. At 7.50, it will be 30. At 7.60, it will be roughly 25. This is a simple method to memorize this complicated table. This is a simple method to memorize this complicated table. And point to note here is, if pH and H plus are inconsistent, as I have shown you in the previous question, here pH is 7.30 and H plus both are inconsistent. The ABG is probably not valid. The ABG is probably not valid. It's the same principle. For pH of 7.30, as I have shown in the question, the H plus should have been 50. It is only 30. It means both are not correlating. Probably it is a lab error, not valid ABG. Coming to low anion gap. We have discussed about high anion gap, normal anion gap. There is also a concept called as low anion gap. We know that this is, let this be Na plus, let this be chloride and bicarbonate. Always between these two there is a gap called as anion gap, and within each compartment there is a measured part. So let this be negative, so it is measured anion. This is unmeasured, this is unmeasured anion. Here also this will account for measured cation, and this will account for unmeasured cation. Like I told you previously, to maintain electroneutrality, the measured and unmeasured in both sides will be equivalent. So I can write it like this, I think. So I can write it as unmeasured cations. There are two compartments. Both compartments will be nearly equal. Plus measured cation, sodium, is equal to, it will be equal to unmeasured anion plus measured anion. What are measured anions? Chloride, bicarbonate. Now changing these sides, Na plus, if I send this to this side, this positive will become negative, minus chloride plus bicarbonate. This is simple mathematics. Unmeasured anions minus unmeasured cations. Now what is the standard anion gap formula? Na plus minus chloride plus bicarbonate. This is the standard anion gap formula I have told you in the ABG-CME. Now can I write this as anion gap? Na plus minus chloride plus bicarbonate? Yes. Anion gap will be equivalent to unmeasured anions. It is dependent on unmeasured anions minus unmeasured cations. This is the ultimate relation, students. We have discussed in high anion gap metabolic acidosis, what happens is unmeasured anions increases in your body. Lactate, formate, oxalate, salicylate. Because unmeasured anions was increasing, anion gap was also increasing ultimately. Now let us see what are the causes of low anion gap. First is abnormal cations in the body, such as lithium or cationic immunoglobulins. Whenever there are plasma cell dyscrasias, there will be immunoglobulins, and these immunoglobulins will be having positive charge, and lithium will also have positive charge. Because of that, what happens? Unmeasured cations increases. So when unmeasured cations increases, when this part increases, automatically what happens to anion gap? It will decrease. See, this is a simple mathematics, students, nothing more than that. Simple mathematics. If anion gap, if unmeasured cations increases, so here the minus is increasing. So minus is increasing. So what happens to anion gap? It decreases. Now second one, whenever there is plasma anion albumin concentration decreases. See, normally most important negative charges will be your proteins, unmeasured negatives, such as in nephrotic syndrome, liver is source of protein. When in liver disease also protein decreases, malabsorption, proteins are not reabsorbed. Now what happens is this part decreases, the positive part, this unmeasured part decreases, this unmeasured part decreases. Whenever unmeasured anions also decrease, anion gap also decrease. This is also a cause of low anion gap. See here students, anion gap can decrease either due to increased cations, increased unmeasured cations, anion gap can decrease, or it can decrease as a result of decreased unmeasured anions. What are the unmeasured anions? Those are nothing but albumin. What unmeasured cations can increase? Lithium can increase, cationic immunoglobulins can increase in plasma cell disorders. Next important thing, whenever there is hyperviscosity, severe hyperlipidemia, whenever there is hyperviscosity and severe hyperlipidemia, what will happen is, because the blood is viscous, it may not be able to, so the electrolyte mission may not be able to detect sodium properly. So when there is hyperviscosity and severe hyperlipidemia, there can be underestimation of electrolytes. In that, most affected will be sodium. In these causes, hyperviscosity and severe hyperlipidemia, there will be underestimation of electrolytes because sodium is underestimated. Sodium value decreases, anion gap will also decreases. Three important reasons for low anion gap: either increased unmeasured cations, decreased unmeasured anions, and underestimation of sodium predominantly, as in hyperviscosity and also severe hyperlipidemia. Then coming to what is this actual bicarbonate and standard bicarbonate in the ABG sample. Actual bicarbonate is the actual measurement of bicarbonate in the blood sample. Normally, how is bicarbonate measured? Bicarbonate is measured by the mission with the help of Henderson-Hasselbalch equation. It is measured with the help of Henderson-Hasselbalch equation. You know that in Henderson-Hasselbalch equation there is CO2. So definitely this value will be markedly affected by PaCO2. For bicarbonate there will be no separate electrode to measure bicarbonate in the ABG mission. So it derives bicarbonate with the help of pH and CO2. That is Henderson-Hasselbalch equation, by utilizing the Henderson-Hasselbalch equation. Because in Henderson-Hasselbalch equation, the predominant parameter is CO2, definitely the bicarbonate will be influenced by the CO2. If the PaCO2 is high, the actual bicarbonate can be dragged higher and it will be vice versa. So whenever there is increased CO2 in your body, because of compensatory phenomena, bicarbonate can also increase. Whenever there is decreased CO2 in your body, because of compensatory phenomena, bicarbonate also decreases. So this actual bicarbonate is under influence of CO2. Point to remember, actual bicarbonate will be under influence of CO2. Now I need a parameter of bicarbonate which is not under influence of CO2, Such parameter is called as standard bicarbonate. Standard bicarbonate is what the bicarbonate would have been normal, had the PaCO2 been normal. If CO2 is normal, in that given patient, what might be the bicarbonate, that is called as standard bicarbonate. We are removing the influence of CO2. Under influence of CO2 is actual bicarbonate. Removing the influence of CO2. Is standard bicarbonate. Removal of influence of CO2. It is standard bicarbonate. So the definition, standard bicarbonate is what will be the bicarbonate if the PaCO2 has been normal. Now the mission will calculate considering CO2 as normal, and it is going to give the bicarbonate value. It is the value that would provide a direct handle on what the metabolic system is exactly doing. If the standard bicarbonate, so just write down this relation. I will show you with some questions so that you will understand better. If standard and actual bicarbonate are correlating, it means there is a metabolic defect. The reason is a metabolic defect. If standard and actual bicarbonate are not correlating, it means all this time the change in bicarbonate, was due to a respiratory defect. Just keep this in mind. I will give you some questions so that you will understand better. If standard and actual bicarbonate, standard means what the mission is telling you from Henderson, actual means what the mission is telling you according to Henderson-Hasselbalch equation. Standard is what the mission is telling you by bringing CO2 to normal. If both are correlating, most probably it is only a metabolic defect. If both are not correlating, it can be a possible respiratory defect. How it happens, I will discuss in 2 minutes. Before that, you should be knowing other parameters also. What is this base excess or base deficit? Base excess actually measures all bases, not just bicarbonate. But for all practical purposes, we consider bicarbonate as an important base. So it is synonymous with bicarbonate excess, bicarbonate deficit. But actually base excess means it measures all bases, not just bicarbonate. Now base excess, the definition is a dose of acid or alkali required to return to normal pH, for the blood to return to normal pH under standard condition. Under standard conditions, what is the dose of acid? If the blood is more alkaline, what is the dose of acid to bring it to normal? If the blood is more acidic, what is the dose of alkali to bring the pH to normal under standard condition? If there is a positive base excess, in very simple words, positive base excess means excess base, that is metabolic alkalosis is present. So normal value is in between -2 to +2 milliequivalents. If the base excess is somewhere 6 milliequivalents, so in his body base is excess. So when will you call base excess? It is metabolic alkalosis. Whereas negative base excess, now if his base excess value is -6 milliequivalents, so it means this patient is having less base. So when will you have less base? When it is a metabolic acidosis. So very simple words, don't get confused. So base excess or base deficit. So this is -6 is base excess of -6 means metabolic acidosis, or base deficit of 6 means metabolic acidosis. Base deficit of 6 means metabolic acidosis. You can use just this term. Don't get confused by using both terms. If base is excess, if it is plus, it means base excess alkalosis. If base is in the minus values, it means metabolic acidosis. Normal is -2 to +2. Negative base excess means reduced base. I have made it into very simple words. Negative base excess means there is reduced base in the body, that is metabolic acidosis. If the base excess is a positive value, significantly positive value, you are dealing with metabolic alkalosis. If it is a significantly positive value, you are dealing with a metabolic alkalosis. You are dealing with a metabolic alkalosis. So this is a metabolic alkalosis. If base excess value is significantly low, it is metabolic acidosis. Apart from base excess, there is another parameter called as base excess standard. What is this standard base excess? Again, don't get confused, students. Base excess is something that we use. Normal base excess is something that we use only blood. But standard base excess is what is the dose of acid or alkali to return ECF to normal pH. Here we are taking the whole ECF. Taking whole ECF into consideration, it is standard base excess. But for all practical purposes in clinical practice, usually standard base excess and routine base excess will be correlating. But for theoretical knowledge, you must be knowing there exists another parameter called standard base excess. Base excess is for blood only, whereas standard base excess, it takes into consideration ECF, not just the intravascular volume. So intravascular volume is only a small part. It will also take the interstitial fluid. So dose of acid or alkali required to return ECF to normal pH. It refers to a model of ECF. The blood volume is diluted with interstitial fluid. Now because we are taking interstitial fluid, so previously it was only blood. So blood hemoglobin will be 15 gram per deciliter. Now we are taking the whole ECF. So now what is happening? So this was the blood which was having 15 gram per deciliter of hemoglobin. Now along with this, so this is whole of ECF. We are also adding the interstitial fluid. Now because of that, this blood's hemoglobin will be diluted. So what we do is, here we take hemoglobin concentration as 5 gram per deciliter. Whenever we are calculating base excess, so in calculation of base excess, because we are calculating with respect to blood, anything when we calculate with respect to blood, we have to take hemoglobin concentration. For standard base excess, the difference is, it is not just blood, it is ECF completely, because ECF also contains interstitial fluid instead of 15 gram per deciliter. So previously this was the volume of the compartment called as blood. So it was, hemoglobin was taken as 15 gram. Now within the blood we are also taking the extra fluid, interstitial fluid. Now what happens to the hemoglobin value here? It becomes diluted because you have added the other component of ECF, interstitial fluid. Now we have to calculate base excess to a hemoglobin of 5 gram per deciliter. In simple words, base excess, routine base excess is nothing but for whole blood. We have to calculate the base excess, taking it hemoglobin concentration 15 gram per deciliter. Standard base excess means it is not just blood, it is the complete ECF. Here we use the same formula for base excess, but we change the hemoglobin value to 5 gram per deciliter. So in simple words, so this is for, in very simple words, what is the difference between base excess and standard base excess? Base excess, for whole blood we calculate base excess taking hemoglobin concentration as 15 gram. Standard base excess, it is not only for blood, it is for the whole ECF. We take hemoglobin concentration as 5 gram per deciliter. For all practical purposes, standard base excess will be nearly equivalent to base excess. So no need to see both separately in majority of the conditions. Now let us see some clinical examples how to assess the acid base abnormality with help of this base excess and difference between standard bicarbonate and actual bicarbonate. Now this is without any symbol. This is C means calculated bicarbonate. This is actual. So this is also calculated, but after removing the influence of CO2, this is standard bicarbonate. So this is standard bicarbonate. Now let us see the ABG disorder. pH reduced, CO2 reduced. For all practical purposes, in ABG you should always use actual bicarbonate only. Use actual bicarbonate for initial interpretation. So C stands for calculated value. Bicarbonate, I told you, it is a calculated value from the Henderson-Hasselbalch equation. So no doubt, decreased pH is acidosis, changes in same direction, so it is metabolic acidosis. Now if you notice here, actual and standard bicarbonate are the same. It means all this time, even if I have normalized CO2, the bicarbonate is not becoming normal. If I have normalized CO2, standard bicarbonate means I am normalizing the CO2. After normalizing CO2 also, See, I have normalized the CO2. Still bicarbonate value did not change. It means all this time the change in bicarbonate was due to metabolic defect. So this is due to metabolic defect. This is predominant metabolic defect. What metabolic defect will decrease bicarbonate? It is acidosis. Now next question. pH 7.4. This is normal value. PaCO2 is decreased. Bicarbonate is also decreased. So bicarbonate is also decreased. Now standard, this is actual bicarbonate. So standard bicarbonate is 20, base excess is minus 7.7. Now whenever base excess is minus, see when the pH is normal, so this base excess and the actual and standard bicarbonate can help you in evaluation. This is normal, but the values of CO2 is decreased, bicarbonate is decreased. So this is showing some acid base disorder. So when will ABG become normal? Either there are normal parameters or there are two mutually opposite disorders. So patient might be having a metabolic acidosis, respiratory alkalosis. Patient might be having a metabolic acidosis with respiratory alkalosis, along with that respiratory acidosis, metabolic alkalosis. Two mutually opposite. One acidosis, one alkalosis. Now let us see, because base excess is in minus value. So definitely there is metabolic acidosis. There is definitely metabolic acidosis. Now instead of calculating expected CO2, I will tell you in a very easy manner to see whether there is a respiratory disorder or not. Now the actual bicarbonate is 18. But when you have standardized CO2, the bicarbonate has increased to 20. It means the actual bicarbonate is not correlating with the standard bicarbonate. Actual bicarbonate and standard bicarbonate is not correlating. So all this time the bicarbonate change was also due to a respiratory disorder. See, if there was no respiratory disorder, see, the actual and standard would have been same. Now you have brought the pH, you have brought the CO2 to 40. So CO2 from 24 to 40 you have brought. So what has happened to bicarbonate? Bicarbonate also slightly changed. So it means actual bicarbonate and standard bicarbonate are not correlating. So there must be an additional respiratory defect also. So what is the respiratory defect that can cause bicarbonate decline? What is the respiratory defect that can cause bicarbonate decline when there is a respiratory alkalosis? You know that when there is respiratory acidosis, it can increase the bicarbonate. Whenever there is a respiratory alkalosis also undergoing, that will decrease the bicarbonate. Now because you have brought CO2 to normal, so this bicarbonate which was decreased previously, it is also coming to normal value. So if you take, this is a graph. This is the graph. So let us say this is 22 to 26 bicarbonate. Let this be 10 bicarbonate. Let this be 30 bicarbonate. Bicarbonate value. Now in this question, if you see here, the actual bicarbonate was 18. I'll write it as A. Now once you have brought CO2 to near normal, it has came to 20. So this is the standard bicarbonate. It means all this time the bicarbonate which was at 18 was also due to influence of CO2. Now tell me, which respiratory disorder can decrease bicarbonate? It is respiratory alkalosis. But still, even after correcting the respiratory disorder, the standard bicarbonate is only at 20. It has not come to 22. It means there is also a metabolic disorder. So this is metabolic acidosis with respiratory alkalosis. So this comparison of standard and actual bicarbonate usually is helpful whenever the pH is normal. You are confused, is it only a single metabolic disorder or both metabolic and respiratory? So it will help you in this condition. So another example, pH 7.45 normal, PaCO2 increased, bicarbonate. So this is the actual bicarbonate, it is increased. Now see the base excess. So base excess is plus 20. Whenever there is excess base, you should think about metabolic alkalosis. So this patient is having metabolic alkalosis. Now see his standard bicarbonate. Now see his standard bicarbonate. So in this question, I'll just represent here. I'll just represent here in this graph. Now let us say, for example, on this side, the higher limit of bicarbonate is 50. Now the actual bicarbonate of this patient, the actual bicarbonate is 47. The actual bicarbonate is 47. When you corrected the bicarbonate by bringing the CO2 to normal, so CO2 was 65. So you brought it to normal, 40. You brought it to normal. You have decreased the CO2 to 40. When CO2 was decreased to 40, this standard bicarbonate has come to 43. This standard bicarbonate has come to 43. It means again the actual bicarbonate and standard bicarbonate are not correlating. It means until this time the change in bicarbonate was not just due to a metabolic phenomena. There is also coexisting respiratory phenomena. So there is a respiratory defect also. Now what is the respiratory defect that can actually increase the bicarbonate? It is respiratory acidosis. So this patient is having both metabolic alkalosis and respiratory acidosis. So in this manner you can tell. Now if you notice here, even after bringing CO2 to normal, it is still at 43. Even after bringing CO2 to normal, it is still at 43. It means there is also a metabolic phenomena. If you brought CO2 to normal, if it has come to here, it was only metabolic. So still it is not coming. So it is both metabolic and respiratory. So point to remember here is, so this is a bit complicated. So simple logic is, if actual and standard are both equivalent, it is only a metabolic defect. If both are not correlating, so if actual is not correlating with standard, so there is possibility of a respiratory defect. You should see the trend of bicarbonate. If bicarbonate has decreased, if the bicarbonate is in decreasing trend, you can see here the bicarbonate is decreased ultimately. So which respiratory disorder can decrease bicarbonate ultimately? Respiratory alkalosis. Here the bicarbonate has increased more than normal value. So which respiratory disorder can increase bicarbonate more than normal value? Respiratory acidosis. So simple steps to assess the actual and standard bicarbonate. If both are equal, you are only dealing with a metabolic defect. If they are not correlating, most probably there is an additional respiratory defect. Now once you have seen both are not correlating, now see the value of bicarbonate. So see the value of the standard bicarbonate. If the standard bicarbonate is less, so what is the respiratory disorder that can result? So less than normal value. What is the respiratory disorder that can cause less bicarbonate as a part of respiratory alkalosis? So whenever the respiratory alkalosis is there in your body, there can be some amount of metabolic acidosis. Now if the standard bicarbonate is higher than normal value, which respiratory disorder causes high bicarbonate? Respiratory acidosis. So same thing we have done here. So by seeing the base excess, I was able to tell it as metabolic acidosis. Both were not correlating, so there is an additional respiratory defect. But bicarbonate is less than normal value. So this is a respiratory alkalosis. In the second question, by seeing the base excess, I have concluded it as metabolic alkalosis, and the actual bicarbonate and standard bicarbonate are not correlating. So there is a possible respiratory defect. Then what I have seen? I have seen the standard bicarbonate value. I have seen the individual standard bicarbonate value. So it is higher than normal value. What causes high bicarbonate? It is a respiratory acidosis. So this is how you should ultimately use the standard bicarbonate base excess for interpreting mixed acid base disorders when the pH is normal. Coming to calculation of bicarbonate deficit, there will be few scenarios, extreme acidosis, where you may need to give bicarbonate. Suppose in DKA pH is very low, less than 7.1, patient is having severe dehydration, is very tachypneic. You think all these are due to some severe metabolic acidosis. So in that conditions, you might replace bicarbonate. How to calculate how much bicarbonate should be replaced with help of a question. There was a 50 kg female with severe metabolic acidosis and has the following parameters. Bicarbonate is as low as 4, pH is as low as 7.05. This is an ideal indication to give bicarbonate to the patient. The approximate quantity that should be received in first 4 hours. So first of all, how to calculate bicarb deficit? This is the standard formula. 0.5 into body weight. 0.5 into body weight. How much is body weight? 50 into 24 minus 4. Bicarbonate given in the question is 4. So that accounts to 25. 0.5 into 50 is 25 into 20. So this is the bicarbonate deficit. So this 500 milli equivalence is the bicarbonate deficit. But point to remember, you should not give all this bicarbonate deficit as a bolus. How much should be given? How much maximum can be given in the first hour? About 50 to 100 milli equivalents. About 50. This is from Harrison 20th edition. So this values 50 to 100 should be given during the first hour of therapy. You cannot give 500 immediately. Half of the calculated deficit should be given in the first 3 to 4 hours. So what we do is, in the first hour we give about 100. In the next 4 hours we give half. So we give, what is the half of 500? We can give about 250, 200 to 250. Now the question they have asked is the approximate quantity that the patient should receive in first 4 hours. So in first 4 hours, you should give half of the dose. If patient not improving, the next 18 hours. In the next 18 hours, you can give rest of the half. So first 4 hours, this patient requires 250, and next 18 hours, he should require 250. So within the first 4 hours, a total of 250 should be given. During the next 18 hours, if the patient is not improving, the next 250 milli equivalents can be given over 18 hours. So this is regarding calculation of bicarbonate deficit. Then coming to renal mechanisms, what happens in type 1 RTA, distal RTA, what happens in type 2 RTA, proximal RTA. So type 1 RTA is predominantly decreased H plus excretion, in the distal nephron, especially in the collecting duct, whereas proximal RTA is decreased bicarbonate reabsorption, in the proximal convoluted tubule. Now let us see what is going to happen here. Let us say, let this be the cell, let this be the urine, and let this be the body side. Now normally in the distal part there is an active pump called as H plus. H plus will go into the urine, K plus will come into the cell, later into the body. Now the problem here is there is this H plus excretion. So because of this H plus excretion are getting affected, H plus can increase in the cells, H plus can overflow into the body. Because H plus is increasing in the body, there is metabolic acidosis. Normally H plus should be excreted out from the distal tubule, because H plus is not getting excreted from the distal nephron. H plus fills within the body. Whenever H plus increases, it is metabolic acidosis. Now whenever H plus is not going out, what will not come inside? K plus will not come inside, because K plus is not coming into the body. K plus is not going into the body, this patient will also develop hypokalemia. In simple words, normally K plus should come in, H plus should go out. Now that is blocked. So H plus will stay in the body, resulting in metabolic acidosis. K plus will not coming into the body, because K plus is not coming into the body. In the body, K plus can reduce, resulting in hypokalemia. Now coming to proximal RTA. Now what happens normally in the PCT is, if this is urine, so if this is the body side, normally from the urine, bicarbonate should be taken towards the body side. Now what is happening? This phenomena is not occurring. Bicarbonate reabsorption is not happening. So lot of bicarbonate will be lost in the urine. Because bicarbonate is lost, there will be metabolic acidosis. Then what is the reason for hypokalemia? The reason is excess bicarbonate in urine. Excess bicarbonate in urine can stimulate kaliuresis. It means this bicarbonate is a negatively charged ion. It will not go single. It can mingle with a positive called as K plus. It will take a K plus along with it, because K plus and bicarbonate both are going. Loss of bicarbonate, metabolic acidosis. Loss of K plus, hypokalemia. These are the causes of metabolic acidosis and hypokalemia in type 1 and type 2 RTA. Whereas type 4 RTA, it is most common type. This is generally due to either aldosterone resistance. It happens either due to aldosterone resistance or aldosterone deficiency. In the body, aldosterone is less or aldosterone is not functioning. Whenever aldosterone is not there or not functioning properly, what will be the phenomena equivalent to? It will be equivalent to hypoaldosteronism. So this phenomena will be just as equivalent to hypoaldosteronism. Now what will be the end result of hypoaldosteronism? It will be metabolic acidosis with hyperkalemia. So point to be noted here. Type 1 or distal RTA. So these both type 1 and type 2 will result in metabolic acidosis, hypokalemia. Whereas type 4, which is most common type, it is similar to hypoaldosteronism like condition. It will result in metabolic acidosis, hyperkalemia. And hyperkalemia. Next important renal disorder causing metabolic alkalosis here, acid-base disorders, will be these: Bartter syndrome, Gitelman syndrome, Liddle syndrome. In Bartter syndrome, the main defect is decreased functioning of Na plus, K plus, 2Cl minus channel in loop of Henle. This channel will not function. Normally this channel is required for water reabsorption. Now this channel is not functioning. Now water will not be reabsorbed. There will be volume loss. Because of volume loss, there will be RAS activity. Like I told you, hypoaldosteronism was causing metabolic acidosis, hypokalemia. Hyperaldosteronism opposite, metabolic alkalosis with hypokalemia. So this will cause a secondary hyperaldosteronism. Excess function of aldosterone will result the patient to land in metabolic alkalosis, hypokalemia. Now coming to Gitelman syndrome. This is due to decreased functioning of a channel called as Na plus Cl minus in distal tubule. Again, Na plus Cl minus is required for water reabsorption. Again, there will be volume loss. Because of this volume loss, there will be enhanced RAS activity. Because of enhanced RAS activity, patient will again land up in metabolic alkalosis, hypokalemia. Whereas Liddle syndrome is predominantly due to increased ENaC activity in collecting duct. Increased ENaC activity in collecting duct. Increased ENaC activity. Normally in collecting duct, if you consider this is the urine, let this be the cells. So this is urine. So I have simplified this diagram. Let this be the cells, let this be the body side. Normally in the collecting duct, if 3 sodium are coming into the body, if 3 sodium are coming into the body from the urine, 2K plus 1 H plus will go into the urine. This is the normal phenomena happening in the kidney. So from the urine, if 3 sodium are reabsorbed, what will be lost from the body? K plus and H plus. Now what happens in Liddle syndrome? There is excess ENaC activity. Now instead of 3 sodium, 6 sodium will be taken into the body. For whatever excess sodium is taken, excess K plus and excess H plus will be lost. Because H plus is lost, it is metabolic alkalosis. Excess H plus is lost. K plus is also lost. Hypokalemia. So there will be metabolic alkalosis and hypokalemia. Now a normal person usually takes only 3 sodium. Now a person with Liddle syndrome is taking 6 sodium. When 6 sodium are taken, along with that excess water is also taken. So this patient will also develop hypertension. So it is an unregulated sodium reabsorption. Previously there was reabsorption because of volume loss. Because volume loss was the trigger, so the ultimate result will be maintenance of the volume. The BP will come to near normal. But here this is an unregulated sodium reabsorption. So there was no trigger called as volume loss. So ultimately what will happen to the blood pressure? It will be significantly elevated. In Bartter syndrome, Gitelman syndrome, metabolic alkalosis, hypokalemia with normal or low BP. So here patient presents with normal or slightly reduced BP. But here patient generally presents with volume expansion. So this completes the renal mechanisms. We have discussed the oxygenation status, the buffering mechanisms, the renal mechanisms of important disorders, what is base excess, what is standard base excess, what is actual bicarbonate, what is standard bicarbonate, validity of ABG. Next we are left out with ABG sampling, how to collect the ABG sample, how to process it, what can be the errors. Okay, so why exactly we need an ABG? It is knowing the acid base balance. Is there any acidosis? Is there any alkalosis? And also knowing the oxygenation of the patient. Is the patient having any hypoxemia? Is the patient in any hypercapnia? So this is the need for an ABG. Now first thing, when you are taking an ABG, it is arterial blood class. So you should make sure you are preparing for an arterial sampling. So whenever you are doing arterial sampling, most important test that you should know is a modified Allen's test. Most important thing that you should know is modified Allen's test. I think most of you must be knowing, no students, how to do modified Allen's test. Before proceeding into modified Allen's test, because it is not just important for your exam, but also in your practice, you should be able to locate the radial artery, you should be able to puncture the radial artery. Before puncturing the radial artery, you should make sure your ulnar artery is patent. Let us see what is the brief history of this Allen's test. This Allen's test was actually described in 1929 by a person called as Allen. Now it has been changed to modified Allen's test. So for all practical purposes, whenever I ask about Allen's test in ABG, you should keep in your mind it is the modified Allen's test. Now what is the basic difference? In Allen's original test, both hands were tested simultaneously. So you used to test both hand arteries simultaneously by compressing one artery of each hand at same time. Right now for ABG analysis, so this Allen's original test is completely outdated. We are not using it. So for rapid knowing the patency of ulnar artery, what we use is modified Allen's test. So what we use is the modified Allen's test. It evaluates the adequacy of collateral circulation, and we are going to test one hand at a time. So in the same hand, we are going to test radial artery, ulnar artery. We are going to test one hand at a time. Whereas in original Allen's test, so we were testing, compressing one artery of each hand at the same time. So we are comparing both hands in original Allen's test. So for all practical purposes, now we are only using modified Allen's test. So modified Allen's test evaluates the adequacy of collateral circulation, but it requires testing of one hand at a time. Now let us see what are the steps of modified Allen's test. First I will tell you the steps, then I will also show you in a live patient how it is done. You should instruct the patient to clench his fist. So first thing, you should ask the patient to clench his fist. So make a fist like this. Next step is you have to occlude both radial and ulnar arteries. So second step, apply occlusive pressure on both ulnar and radial arteries. So you can do it on yourself. So very simple. You ask the patient to clench his fist and you are going to occlude both arteries. So radial and ulnar artery. After some time, you ask the patient to open his fist. So whenever he opens his fist, because you have blocked both arteries effectively, this hand will be pale, less blood. Now what you need to do is you have to remove the pressure from ulnar artery. So on removal of pressure from ulnar artery, if your hand turns pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke the corresponding radial artery. See here. You ask the patient to unclench and one can observe the paleness of hand. So this is very, very important. On release of pressure on the ulnar artery, once you release the pressure from ulnar artery, you are going to see whether the test is positive or negative. So positive means hand should turn pink within 5 to 15 seconds. This is the waiting time. So they can ask you within how much time you should be able to interpret modified Allen's test. It is 5 to 15 seconds. Ulnar artery patent means modified Allen's test positive. I'll show you with an example. See, this is one of my patient. So first thing is I am going to ask the patient to make a fist like this. Okay, he is going to make a fist like this. So after that, so with my two hands I am blocking both radial and ulnar artery. I am blocking both radial and ulnar artery. Okay, after some time I ask the patient to open his fist. I request him to open his fist. Once he opens the fist, you can see because I have blocked both arteries, the hand has become pale. The hand has become pale. Now what I need to do? I have to release the pressure from ulnar artery. After release of pressure, within 5 to 15 seconds, the hand should become pink. If a hand becomes pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. You can see in this image. First, this was the condition of his hand, lot of paleness. Now it has become pink. So very important concept here. On release of pressure, everything starts with the letter P. On release of pressure from ulnar artery. On release of pressure from ulnar artery. If hand turns pink, if a hand turns pink, it means ulnar artery patent. Ulnar artery patent. Ulnar artery patent means the Allen's test, the modified Allen's test positive. Allen's test positive means you can poke radial artery. This is what I teach all my postgraduate and interns. They will be very much confused when to call it as positive test, negative test. Simple mnemonic. Everything starts with the letter P. On release of pressure from ulnar artery. If a hand turns pink, ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke radial artery. Now this was a patient in whom I thought of doing ABG sampling. Now this Allen's test is positive and I can poke his radial artery. I can poke his radial artery. So next thing, now I am thinking to poke his radial artery. How to proceed further? First thing, this is the screening test done. Modified Allen's test to know the patency of ulnar artery. Now because ulnar artery is patent, even if I poke radial artery, if at all there is some circulation delay here, these fingers will be receiving circulation from ulnar artery. There will be no issue with the patient's hand circulation. So this is the test for you to see again. I have made a fist, then I have blocked both arteries. Initially, when I have blocked, this hand is pale. Now when I have released the pressure, it has become pink. Students, if they ask you any question about modified Allen's test, you should not make any mistake. I have shown you this common word procedure with help of an example also. No student should get confused on modified Allen's test. And if you are going to your ward, you can try it on any of the patient so that you will not forget how to do this test. Then coming to arterial blood sampling. Now this patient, there is positive modified Allen's test. Now I want to puncture his radial artery. First thing, perform hand hygiene and disinfect the sampling site with the help of 70% alcohol and allow it to dry. Then you should hold the syringe and needle like a pen or a dart. You can hold the syringe with like a pen or like a dart and use the index finger to locate the pulse, and this is very important. So with how much angle you have to insert the needle. So it is 45 degree. So 45 degree, approximately 1 centimeter distal to the index finger. No need to write everything. I will show it on images. You will understand better. Now advance the needle into radial artery because it is an artery. When you just go into the artery, you can see blood coming into the syringe without applying any pressure itself, because arteries are high pressure systems. If you just put the needle, so blood, you can see a tinge of blood coming back into the syringe, and allow the syringe to fill to the appropriate level. So withdraw the needle and syringe. So once you have taken the blood, you should apply firm pressure on that puncture site, because it is an arterial puncture. Bleed sometimes can be torrential. So once you remove, you should apply firm pressure. So very simple technique. First clean the site, insert the needle by palpating the pulse, 45 degree angle, and once you got the blood, you are going to close the puncture site with some pressure. Now I will show this. This is the same patient in whom I have performed modified Allen's test. Now you can notice here, I am making things ready for sampling. So usually you can keep support below the wrist. So whenever you keep support below the wrist, you can slightly extend the hand so that you will have good space to palpate the radial artery. Now see this. So step by step, I am palpating the radial artery with my index finger. I have palpated. All sterile technique should be followed. And that syringe was a pre-heparinized syringe. So why to add heparin? Because ABG machine cannot process the clotted blood properly. Now I have inserted the needle 45 degrees. I am holding it just like a pen. Now you can see a red color blood coming directly from the artery. So it was very bright red. It was very bright red. You can see the blood coming into the syringe. You can see the blood coming into the syringe. Okay. So once I got the required amount, I asked my assistant to hand over the cotton and I am going to place an occlusive dressing. So you can see the blood is very red. It is very bright red. So bright red blood is always suggestive of arterial blood. Have you seen this? How to take a arterial blood gas sampling or arterial sampling? I am palpating the vessel. So whenever I have found out the pulse, okay, so I am using my index finger predominantly, then I am holding the syringe just like a pen, 45 degrees angle I have inserted. See the position of the hand of the patient. Then once I have seen blood coming into the needle, I can see a flashback of blood. So now I am aspirating, so I am collecting the required amount. So generally we collect 2 to 5 ml of blood. After that, I am going to remove the needle. By seeing the color of the blood, I am sure it is arterial blood. My assistant is giving an occlusive dressing. I am fixing it with pressure so that there is no bleed. So this is how you should collect arterial blood sampling. Now this was a question asked in previous exam. An intern was asked to draw blood for ABG analysis. What is incorrect? Let me know the answer. So is it flexing the wrist, insert needle at 45 degree angle, perform modified Allen's test, or rinse the syringe with heparin? Generally, insert the needle at 45 degrees is a right statement. Performing modified Allen's test is also a right statement. Excuse me. Pre-heparinize with heparin so that blood does not clot. This is also right answer. We are not going to flex the wrist. See, if you flex the wrist like this, there will be no space for you to palpate and to get the sample. Generally, we try to extend the wrist. The answer is you are not going to flex the wrist. So this is regarding modified Allen's test. Now we have identified that this patient's radial artery is patent. I have punctured the radial artery and I have taken the blood. Next is, what are the common errors? Now you are a newbie. This is the first time you are doing arterial blood gas sample collection. What will be the common errors? Common errors means sometimes you might accidentally puncture the vein. Or else there can be mixed venous blood. And air bubbles in the sample. So when you are taking the blood, there might be air bubbles and you might have forgotten to expel those air bubbles. And inadequate or excessive anticoagulant. Either you did not add heparin properly, or in panic you have added excess anticoagulant. And next important thing, you might be in a ward where ABG machine is not available. You might need to transfer it to another center which is about 1 hour far away. So you don't know that it should be kept in ice. So you might give it to the patient attendant and send it like that only. So delayed analysis of a non-cooled sample. Students, I need to know, you will come across non-arterial samples, air bubbles in the samples, inadequate or excess anticoagulant in the sample, delayed analysis of a non-cooled sample. Now, how to identify all these mistakes and how to get yourself corrected? First thing, when do you call it a venous sample? Suppose you have taken blood and you have sent it to ABG analysis. You should. So just wait, Kinal. Just to be patient, I'll tell you how to use heparin. Just wait for a while. So venous sampling. So venous blood from the well perfused patient may provide a gross indication of acid base from a well perfused patient. Gross indication of acid base status. See, if the patient is well perfused. So if the patient is well perfused, it means his SpO2 is normal. So you can use venous sample for assessment of acid base disorder, because in vein the pH, vein in pH and artery, it will be nearly the same. Only difference will be the oxygenation. Only difference. See, arterial blood oxygenation will be very good. Arterial blood oxygenation will be very good, whereas in venous blood it will be very less. And O2 saturation in arterial blood, it will be always 95%. And moreover, see here, the difference here is generally O2 saturation will also be calculated by the mission. So this is called as SaO2, saturation of oxygen in the artery. It is calculated by the mission. So it is calculated by oxygen hemoglobin dissociation curve. It is calculated generally by the oxygen hemoglobin dissociation curve. Generally, if it is a venous sample, what happens is oxygen will be in the range of 35 to 40. So the oxygen saturation, the SaO2 will be less. Now, how to exactly tell it is a venous sample? If you suppose, if patient's SpO2 was somewhere 90 to 95, but patient's SaO2 is 70 to 75. So it means most probably it is a venous sample, because in venous sample always oxygen will be less. So based on this oxygen, by using the hemoglobin oxygen dissociation curve, SaO2 is calculated by the mission. So SaO2 will be less. But if you see with a pulse oximeter, SpO2 will be more. When you see this difference, most probably you are dealing with a venous sample. Most probably you are dealing with a venous sample. And also carbon dioxide will also not be much different, and bicarbonate will be nearly the same. Bicarbonate will be nearly the same. So the most important parameter changing in vein is the oxygen. Significant difference will be the oxygen saturation. If they ask you what is the main difference between arterial blood and venous blood in ABG analysis, your answer should be this: the oxygenation, partial pressure and oxygen saturation will be significantly affected. Which parameter will be usually same? Usually same will be the bicarbonate. So much difference it will be generally similar. So slight difference, we have pH, PaCO2. Slight difference will be pH, PaCO2, but that can be manageable. But significant difference will be in the oxygen values. How to find out it is a venous sample? See the patient's SpO2. So if the difference between SpO2 and SaO2 is significant, most probably you might be dealing with a venous sample. The venous sample, how to identify? Tell me, what is this sample? This is arterial. You can see bright red. And what is this sample? This is venous sample. This is venous sample. These are the important points by which you can recognize. First thing, failure to observe a flash of blood. I told you, whenever you put it in a artery, because arteries are flowing with high pressure, generally the blood without suctioning itself, it will come into the needle. This is called as flash of blood. Next, incompatibility of values with clinical condition. You might see patient having a good SpO2, but when you have seen the ABG, his SpO2, his SaO2 might be less, his PaO2 might be less. So this is important. Low PaO2 and high PaCO2. So generally I told you, in venous sample, oxygen levels will be less. Oxygen levels will be less. Patient is comfortable and he is having SpO2 of about 95%. But when you have seen in the ABG, his PaO2 was 45 and his SaO2 was somewhere 70-75. It means it is not arterial blood, it has to be venous blood. And this is the thing I have told you, SpO2 by pulse oximetry much more than SaO2 by ABG analysis. Why SaO2 is affected here? Because SaO2 is calculated by the oxygen hemoglobin dissociation curve. It will take the value of PaO2 and it will give SaO2. Because PaO2 is less in venous sample, SaO2 will also be less in venous sample. This is the most important method by which you can find it is a venous sample. Patient's SpO2 will be good, but SaO2 in ABG will be less. PaO2 in the ABG will be less. And during sampling, you should be able to identify these two colors. Bright red is arterial, dark red is venous. When you put in the vessel, you should be able to see a flash of blood coming into the needle. This was a question asked recently. To interpret a acid-base disorder, following helpful. I want to identify acid-base disorder in a patient. So these were the parameters given. To accurately identify acid-base disorder, which will be the helpful options? Which will be the helpful options? Yes. pH of arterial blood, is it reliable? Yes. CO2 of arterial blood is also reliable. Oxygen of venous blood is generally unreliable, whereas bicarbonate of venous blood and bicarbonate of arterial blood will be the same. The best option will be that containing A, B, D. This will be the best option. Even in your clinical examination, if at all they want to ask you about acid-base balance, they'll ask you, what is the difference between arterial sample and venous sample? Arterial sample and venous sample, most important difference will be oxygen. pH and CO2 will correlate, but bicarbonate generally will be in the similar lines. You can use pH of arterial blood, you can use CO2 of arterial blood, bicarbonate of venous blood. Oxygen of venous blood, you cannot interpret with the oxygen of venous blood. Next important aspect that I see is air bubbles. Few interns, what they do is they take good sample, but they leave air bubbles and send it to the ABG machine. That's why I am getting some false values. Let us see what can an air bubble do. Air bubble is nothing but air coming from the atmosphere. Atmosphere also there will be oxygen. That oxygen will interfere in the oxygen of the blood and it can change the value. See here, room air has a PaO2 of approximately 150 mmHg. You must be knowing what is the partial pressure of oxygen in the atmosphere. It will be 150 mmHg. And generally in the atmosphere carbon dioxide is very less, it will be nearly zero. It will be nearly zero. The air bubbles that mix and equilibrate with arterial blood will shift PaO2 towards 150 mmHg and lower the PaCO2. Now suppose if patient's PaO2 is about 60 mmHg, let it be 60 mmHg. Now there is an air bubble. This air bubble will have an oxygen of 150 mmHg. Now because of this, both will equilibrate and give rise to falsely high values. So this is also another important question. If at all there are air bubbles, what it can do? It can equilibrate with the arterial blood and it can give some false values. Let us see an example. I have taken an ABG without air bubbles. So just to show to my intern, without air bubbles, with air bubbles. Actually my intern has sent me the sample with air bubbles. I have incorporated that report and also without air bubbles. So with air bubbles, when the report was taken, PaO2 was 90 mmHg. Why it is 90 mmHg? Because air bubble is also containing oxygen. So air bubble is also containing oxygen. With air bubble, actual PaO2 of the patient is 70 mmHg. Actual PaO2 of the patient is 70 mmHg. Because my intern sent the sample with air bubbles, it was given as 90 mmHg. It was given as 90 mmHg because the air bubbles oxygen has added to this oxygen. PaCO2 has slightly decreased because PaCO2 in that air bubble will be less. So it will try to decrease the CO2 of the blood. In the question, if they mention what is the effect of air bubbles can have oxygen in it. When mixed with arterial blood, it can give false values. So these are the situations. Suppose patient is in hypoxemia. You want to know what is his PaO2. You have given him some treatment, whether he has improved or not properly. If at all there are more of air bubbles, his PaO2 will be falsely high. PaO2 can be falsely high. The next problem is delayed analysis. Like I told you, because ABG mission is not available at each and every center, you might take a sample and you don't know how to transport it properly. Because of delayed analysis, what can be the ABG abnormalities? You have to analyze within 30 minutes. Many studies tell you that ABG should be analyzed within 30 minutes. When analysis is expected to be delayed more than 30 minutes, use of glass syringes and ice slurry is recommended. Why we have to use glass syringes, I will tell you later. So just keep this in mind. Whenever analysis is expected to be delayed for more than 30 minutes, it is better to use glass syringes. Why to use glass syringes? What is the difference between glass syringe and plastic syringe? Just I'll tell you in a while. And ice slurry. So why will you use this ice? To decrease the rate of metabolism. You have taken blood and blood contains cells. If at all you keep the sample like that only, these blood cells will undergo metabolism and can produce some false values. What are these false values? Because still there are live cells, cellular metabolism continues after the blood is collected. Problem is the cellular metabolism continues. These leukocytes and platelets will consume oxygen. These leukocytes and platelets will start consuming oxygen. Once they start consuming oxygen, what will happen? There can be the drop in pH, glucose and PaO2. Oxygen value decreases. Because of consumption of glucose value can decrease. And why pH decreases is, once the oxygen is consumed, now there can be some anaerobic metabolism. Because of anaerobic metabolism, lactate can increase. There can be lactic acidosis that can decrease the pH. Important changes are oxygen value drops, pH will drop, and lactate can be falsely elevated. These three are important for me in clinical purpose. pH will be decreased, PaO2 will be decreased, lactate can be increased. Other values, even there can be increase in PaCO2 because metabolism is happening, carbon dioxide will be released. PaCO2 will be increased, ionized calcium can also increase. But important for clinical practice are decrease in pH, decrease in PaO2, elevated lactate, elevated CO2. This is what happens if you delay the analysis. If you delay the analysis, the blood cells will consume oxygen. They can result in reduced pH, reduced oxygen, increased lactate and increased PaCO2. What is the solution? Use of glass syringes if you feel it will take more than 30 minutes, and sending it in an ice pack. Very important, delayed analysis. Next thing, how much heparin should be taken and what is the method? Generally, we have some pre-heparinized syringes. So whenever there is a pre-heparinized syringes, nothing to worry. Already the amount of heparin required for the blood will be placed. No need to worry. But if at all you are not having a pre-heparinized syringe, generally what is our practice is we take some heparin and we flush. But ideally it should be of this concentration. See, if somebody asks how much heparin should be used, 0.05 ml is required to anticoagulate 1 ml of blood, because the same amount is roughly equal to when you take a 5 cc syringe and you flush it. So it will be approximately equivalent to the heparin that you want to take like this. So that's why we generally flush. And this is very minimal amount. But if they ask you in exam, what is the exact amount of heparin to be taken? If you want to be sure, it is 0.05 ml heparin is required to anticoagulate 1 ml of blood. Now suppose you are having a 5 cc syringe and you want 4 ml of blood. For 4 ml of blood, how much heparin is required? For 1 ml, it is 0.05 ml. For 4 ml, roughly it will be 0.2 ml. So studies have shown that when you take heparin and flush with a 5 cc syringe about 1 ml, ultimately 0.2 ml was remaining. So this will be sufficient. But if they exactly ask you, best is using a pre-heparinized syringe. Pre-heparinized syringe will be having this quantity in that syringe. And if that is not available, you can just flush it. But if they ask you the exact number, 0.05 ml of heparin is required to anticoagulate 1 ml of blood, we generally flush the syringe. So that will be approximately equal to this much. For 5 cc of syringe, 4 ml of blood you are taking, for example, so 0.2 ml. So generally for ABG analysis, 2 to 4 ml of blood is taken. So that's why heparin will be in the range of 0.1 to 0.2 ml heparin used. So this is the statement. How much heparin is used generally for ABG analysis? 0.1 to 0.2 ml heparin used. And heparin, it has slight acidic properties. Now suppose you have taken 1 ml of heparin. So you have taken heparin more into this syringe. Because of its acidic properties, it can affect the pH. It can also alter PaO2 by PaCO2 by dilutional effect. Now instead of blood, there is excess heparin. Because there is excess heparin, now the solution will be diluted. Because that solution will be diluted, the PaO2 and PaCO2 values can alter. Heparin directly can affect the pH because of its acidic properties. And also because when you take more heparin, what will happen is it can dilute the blood, reducing in low PaO2, PaCO2. If you take excess heparin, this is the problem. If you take less heparin, what is the issue? Less heparin will cause clotting of blood. And clotting of blood is not at all a good sign, because if the blood is clotted, the ABG machine cannot process the sample. For all practical purposes, it is 0.1 to 0.2 ml heparin is used for ABG sampling. Then what is the importance of a glass syringe? Even though we are not using glass syringes nowadays, it was used in previous days. Now what is the advantage of glass syringe with respect to plastic syringe? This is just for academic purpose. Glass syringe, the problem is, if at all oxygen is high, it can diffuse out from a plastic syringe. Now suppose you have given FiO2 of 50 or 60% to the patient. Now his PaO2 will proportionately increase. Now suppose his PaO2 has reached about 220 mmHg. In the atmosphere, PaO2 generally is 150. Now these plastic syringes can be permeable to oxygen. So this oxygen can go out. From the syringes. And whereas glass syringes, they are actually impermeable. Glass syringes are impermeable to oxygen, and PaO2 will be more or less unaltered for about 3 hours in an iced sample. So either oxygen can go out if it is high, or within the sample if it is very low, oxygen can also from the atmosphere can diffuse it. If it is a plastic syringe, if you are doing it within 15 to 20 minutes, there is no problem at all. If it is taking more time, about 1 hour, 1.5 hour, then preferred will be glass syringe. If they ask you which is the best syringe for ABG sampling, your answer should be glass syringe. Why it is so? Because glass syringe is not pervious to oxygen diffusion. From a plastic syringe, oxygen can diffuse, causing the values of oxygen false, making the values of oxygen false. So that's why you should prefer glass syringe according to many of these studies. But for all practical purposes, glass syringes are not available everywhere, and we are now doing ABG without 15 to 30 minutes. That's why we use plastic syringes. You can use plastic syringes, but keep in mind, if it is delayed, make sure you are covering it with ice pack properly, and make sure you are doing the sampling very fast. So within 30 minutes, if you do, there will be no difference between glass syringe or plastic syringe. Try to solve this question, students. Which of the following is a wrong related ABG analysis? All these questions were previously asked. Wrong related ABG analysis. Wrong related ABG analysis. We know that most common used is radial artery. If modified Allen's test is negative, opposite hand is used. Modified Allen's test is negative means your ulnar artery is not patent. If your ulnar artery is not patent, you should not poke the corresponding radial artery. Even though pH and PaCO2 are normal, don't consider it as a normal patient. There are many diseases where the ABG parameters can be normal. Initially, ABG parameters can be normal, or if it is a mixed metabolic disorder. Suppose patient is having a metabolic alkalosis and metabolic acidosis together. He is having some renal failure which can cause metabolic acidosis, and he has developed vomiting, metabolic alkalosis. If there are two mutually opposite metabolic disorders, what can happen to pH and PaCO2? The ABG parameters can be normalized. Whenever you see a patient, and most important in ABG is clinical history. Even if the parameters are also normal, don't think this patient is not having any disease. There are so many diseases where ABGs can be normal. And whenever there is a double metabolic disorder, patient is having combination of metabolic acidosis, metabolic alkalosis. I told you an example, renal failure and vomiting. These ABG parameters can be normalized. This is also a true statement. It is not 1 ml of heparin. 1 ml of heparin should not be used for ABG sampling. It is 0.1 to 0.2 ml. It is 0.1 to 0.2 ml heparin.